Hi everyone. So let's just wait for 2 more minutes for a few more people to join and then we'll get started with today's Q&A session. Yeah. Okay, I think we can get started for today. So welcome everybody to another uh, problem solving session. Yeah, good evening. Uh, Today we'll cover the topics, some of them that were in your coursework in week 3, and cover some questions as well. Hopefully that will be useful to you. So I'll share my screen and just let me know if you have any problem seeing it. Right. I hope my screen is visible to everyone.
Yes, ma'am.
Okay, great. Okay, cool. So, right. So last week we covered a bunch of topics mostly relating to cardiac muscle anatomy and the electrical regulation of the heartbeat. And we looked at the PQRST, ECG signature, and we looked at dissected it to figure out what different parts of it are. So which wave corresponds to which event during um, during the cardiac cycle, and we looked at rhythmicity and the importance of each of these events, right? And we talked about different types of ion channels. So this week, we continue on in how the sort of circulatory system is being regulated. So now, not only do we look at the heart, but we also then go on to look at some details about blood vessels and all, right? So uh, before I go on, of course, I'll do a quick recap like I do for last week's stuff. So we can just move through that to make sure that we're all on the same page with respect to what was just uploaded in the last week, because it has some relevance with respect to what is there in week 3, right? So, of course, in week 2, what did we see? We looked at uh, the cardiac tissue structure. So we looked at how there are these different slightly different structures of cardiac muscles and cardiac tissue architecture with respect to skeletal muscles, where skeletal muscles are long and multinucleated. Here you have singly nucleated divided structures which have these intercalated discs in between them, and and very importantly, there are these branches, and these intercalated discs contain adherens junctions, desmosomal junctions, gap junctions, which are important for functional connectivity between cardiomyocytes, right? So they help with transmission of electrical activity as well as mechanical activity, and that's how the functional connectivity works at the intercalated disc. And we also learned about how the T tubules are larger and more developed in the case of cardiac muscles because the sarcoplasmic reticulum is less developed. Because a lot of extracellular calcium is important when it comes to the cardiac muscle rhythmicity, right? So when it comes to the uh, sort of ionic potentiation of the of heart rhythm, extracellular calcium plays a major role, which is why I have very developed T tubules and oh sorry, yeah, I've written it here. Yeah, so yeah, you have very developed transverse tubules or T tubules, which allow for good excitation contraction coupling. So as I mentioned, striated branch cells have many mitochondria, of course, involuntary control. So you have the autonomous nervous system, which we'll talk about. That's highly important in this type of muscle contraction. And each myocyte has a centrally located single nucleus, and you have these intercalated discs, which have these different kinds of functional components, and the T tubules, right? So that's about the cardiac tissue. So then we also talked about the electrical conduction within the heart, how this electrical activity works. So what are the different phases when it comes to the cardiac cycle, right? So in cardiac muscle contraction, initially you will have this. So if you're looking at it from, say, a probe in the ventricle, so initially you will have this. Initially, obviously, the cell is at resting potential. So you have it at around minus 85 millivolt, meaning that if you imagine that the outside is zero, then you are in negative on the inner side. So your negative charge decorating the inner side of the membrane. Then you have a phase of phase zero. Just a second. Yeah. Which is your depolarization phase. You have these fast sodium channels that open, and then you have this spike in the potential, which is called depolarization. So depolarization leads to activated state or contraction, while hyperpolarization is the opposite of that, right? It leads to relaxation or inhibition or deactivation, right? So this one spikes all the way up to like plus 20, plus 35 or so. And then you have phase one, where these voltage gated Na plus channels, they close because these stay open for a really short amount of time. And then you have these voltage gated potassium channels that start to open, and there are these slow leaky channels that are open, which is why you are slowly losing some amount of positive ions from the cell, because as we know, the cell is with respect to the extracellular matrix, cell has a much higher concentration of potassium ions. So the gradient is always in the favor of efflux of potassium. So if you have leaky channels, you're going to have some potassium ions just sort of flowing out of the cell. So now we have a slight drop and then a plateauing. So why does this plateau happen? Because you have K plus efflux that's continuing, and then you also have these slow L-type channels of calcium, right? So these are voltage-gated calcium channels that are opening and slowly taking in calcium from the outside. So now you have this balance of positive charge entering and positive charge leaving, and so you have a plateau. And then these calcium channels close. So now what happens? So now you only have a net efflux of positive ions, which is your potassium ions. So in that case, you start having this phase of rapid repolarization, meaning you're coming back to the baseline or going back to a less activated state. So that's your phase three. And finally, you have your phase four, where you go back to your resting potential or resting membrane potential and get ready for the next round of stimulation. So during this period, when you have these different phases ongoing, there's a refractory period, essentially meaning that you cannot have, at least in the heart, you cannot have two of these pulses sort of occurring at the same time, because what would happen then is it would lead to irregular rhythmicity of the heart, right? Because if you have random firing that's not in a more regulated fashion, the heart will just start going crazy, right? And then you don't have the sort of even heartbeat that one would require. That doesn't mean that your heart can't beat fast or slow, but that is also happening in a regulated manner. So if you're running, it does not mean your heart is beating irregularly. It just means it's beating faster, but it's still regular, you know? So anyhow, this is an important concept that we learned last time. So I thought I'd recap it. And of course, this I'm sure all of you know very well. We talked about the sort of circulation in the cardiopulmonary route. So where the blood comes in from, you have it. So imagine all the blood in your body is sort of pooling up and coming into the vena cava. It enters the right atrium or the right auricle, goes into the right ventricle, is pumped. So at the right atrium, it's quite low pressure. Then it goes through a valve here, and then it goes from the right ventricle into the pulmonary artery, which then carries it to the lungs, oxygenated there, comes to the left atrium, goes to the left ventricle, and then is powerfully pumped into the aorta, which distributes it in the body. So this I think we're quite clear with. So now we learn a little more in detail about sort of what's going on with respect to the pressure balances in these. So of course that was covered really nicely in the coursework. I won't go into it in very great detail. We'll just look at some questions, but we can cover the basics. We also, of course, learned about PQRST, which was also covered in week 3 as well. So I thought I'd go over it once more. So this sort of reading is what you would see in an ECG, right? And an electrocardiogram. So if you go for a routine checkup, or if someone has had some sort of like chest pain or something, they would go to the doctor and say, oh, I've had this problem, and then they will take a quick ECG. So they'll put some leads on you. So if you've ever had one, it's like they take these leads, essentially electrodes, right? And then they stick it onto your skin, and they stick it, I think, near your chest. They stick some on your legs, as far as I remember. And then there's like a whole bunch of them. I'm not exactly sure how many, like I think nine. Don't maybe you should check it out yourself because I don't remember. But yeah, so some X number of leads, and then those will take these very faint electrical recordings that you can get through the skin, and that's what you get in this readout. So this electrocardiogram is going to give you give you information about whether the electrical activity of your heart is regular or not. So coming back to what each of these components of the ECG sort of wave means. So I'm sure you guys remember that the P wave is important for, is representative of atrial depolarization. So what does that mean? It could be atrial systole also, right? That the atria are pumping the blood actively into the ventricles. So during this time, the atria are contracting, the ventricles are relaxed, that will allow them to fill up with blood. And then this during this PR segment, the ventricles are in diastole, essentially. They're relaxed. And then once they're filled up, then it's time for the ventricles to contract. So then there is rapid depolarization in the cells in the ventricle, which allows the heart, the ventricles of the heart to contract. And that is this QRS complex. So that allows the blood to then be pushed from the ventricles into the uh, into the respective blood vessels, right? So that will occur, and then you obviously need to come back to baseline so that you can go for the next cycle. So during the ST segment, you have full depolarization and ventricular ejection has taken place. The semilunar valves are open, allowing the blood to go into the vessels, into the aorta and the pulmonary artery. And then once that has happened, you finally have the T wave, where your ventricular repolarization happens. So what does that mean with respect to ionic sort of the ionic sort of way of looking at it is that you have your cells coming back to resting membrane potential, right? That way, then you're ready for the next round of depolarization, where essentially you're going from -85 to 35, and then plus 35, and then you're plateauing, and then you're dropping down, and then again you are coming back to baseline, and then you're starting again, right? So this is essentially the end of that cycle. And this all conduction is happening within the from the SA node to the AV node via these bundle of His and these different fibers, and that is allowing this innervation and this electrical activity to be transmitted within the heart muscle. And this is from your coursework itself. This was a nice diagrammatic representation of the timings of these different components of the wave, right? So yeah, and this is how the electrical impulse or the excitation is sort of transmitted within the heart. So initially, this is again from your coursework. So again, your sinoatrial node, SA node, right, which is the pacemaker of the heart, it generates an impulse. That's when your atrial excitation begins, right? So depolarization in the atria begins. So that's your P wave, right? And then uh, you have this impulse going to the AV node, but it takes a second, okay, like takes some time. And then from the AV node, so this is during that time you have your P wave completing and you're moving to your QRS. So once it's at your AV node, then it has to pass into the ventricles, right? So this from your AV node, this electrical this excitation has to reach into the ventricle musculature. So once that's happening during the like PQ segment, and then you start your QRS complex. So that's when full ventricular excitation or depolarization or systole, whatever you want to call it, all of that will happen and the blood will move out. Okay, so I hope this is clear. If anyone has any questions, you can absolutely stop me in between and ask away. Right. So, yeah, so I had a few questions just to finish the recap because this content was there in both week 2 and week 3. So I thought it's relevant for you guys. So, as to those who don't know how we do this in these sessions is that I'll show this question and then you can just send the answer in the chat, or if you feel like it, you can also unmute and say the answer. So then based on that, we can discuss. So you guys can send the answer to this one. Uh, what what is the QRS complex representative of? Which of these answers? Yeah, I'm getting some answers. I hope the others are also awake. It would be great if everyone can participate. Probably you guys already know this, huh? Yeah, great. So I think this is simple enough considering I just went through it also. Yeah, I think everyone's getting it right. Good job. Okay, so now what is the T wave representative of? This is the next question. Yeah, yeah, awesome. So I think this is now nicely fixed into your minds, and that's good. Yeah, good to have this knowledge. All right, so one more question. So, if the number of RR stretches increases drastically in an ECG, so in one ECG, you have a lot of number of these RR stretches. What might that indicate? Note, I did not say the distance of RR stretches or the length. I said the number. So, what could this mean? Hmm. So, I have some people saying C. Ah, so the answer is B actually, tachycardia, because if you have the number of RR stretches increasing, that just means that the heart is beating really fast, right? Really rapidly. So the number of stretches within the same length of, say, within the same time, let's say, or the same sort of sheet of ECG paper is going to be more, right? Whereas if the stretch itself lengthens, then that will say something else about what's happening to the heart. Cardiac arrest is when the heart is like stopping. So I don't think you're going to see more RR stretches in that case. It will probably be a either irregular leading to flat kind of a readout, right? But I don't think it will be number of RR stretches necessarily increasing in that way. So the answer here is tachycardia. Okay. So I hope that's clear. If anyone has questions or want to sort of discuss this with me, please keep in mind that I am not a doctor. So there is only so much so much insight I can have here. But from what I have surmised so far is that if you have more of these sort of repeats, then you're gonna have like more beats within a particular X amount of time. So that's tachycardia, essentially meaning that your heart is beating really rapidly. Bradycardia is the opposite of that, where it's beating much slower than it should. And obviously, A option doesn't make sense, and cardiac arrest means that the heart has stopped. Now, last question for the recap, and then we'll move to the new material. So, true or false? The SA node and the AV node conduct electrical impulses simultaneously. Yeah. Oh, interesting. So for till now, we have 50% saying false and 50% saying true. Does anyone else want to try? Hmm. Does anyone else want to try? So I think now the population average is skewed towards true here, but actually the answer is false. Okay, so if these were to conduct impulses simultaneously, You guys can imagine what will happen. So SA node is conducting impulses, essentially the electrical impulse to the atria, right? And the AV node is conducting electrical impulse to the ventricles at the same time. So what would happen? Both of them will try to contract at the same time, right? And will that will completely disrupt normal cardiac rhythm because there has to be a delay such that your atria and your ventricles contract one after another, because the whole point of cardiac the cardiac cycle is that you have this polarized movement of blood, so it doesn't go backwards, that's why you have valves that open in a certain way. You have the atria contracting first and then the ventricles. Everything is positioned in the movement of blood in the pathway such that there is a unidirectional movement of blood, meaning from atria to ventricles and then from ventricles to the blood vessels. So if we have SA node and AV node firing at the same time and conducting electrical impulses into the musculature of atria and ventricles respectively at the same time, then you're going to have contraction of everything at the same time, right? And that could cause all sorts of problems. So I guess if someone had a heart issue, like if I don't know if that happens, but if some patient had a heart issue where there are these problems, right, where people will have misfiring of the pacemakers, or people have to have artificial pacemakers put in. And actually, that's a very interesting topic. So let me know if you guys are interested. I can talk a little bit about the sort of devices that are used in that. That's just as an extra, maybe in the next class. So anyhow, if pacemakers misfire, or like or some issue happens with electrical activity. In fact, what sometimes doctors do, right, is that if someone's heart is beating very erratically, um, like this fibrillation and that kind of thing is occurring, then what I've read is that doctors can essentially give a shock. So the heart is beating really weirdly, right? So you have fibrillation, you have sort of very uncontrollable and irregular beating and contraction in the heart. So they shock the heart. It's like a reset button. It's like restarting the system. Obviously, it's not foolproof, but that is one of the things that doctors try, is to shock the heart such that the resets and you have the electrical impulses sort of regularized again. So all of that basically was to just reiterate the fact that there is a specific order of things in the heart. So you start with your SA node firing, that then conveys this electrical impulse to the AV node. During this time, there is a delay at the AV node. Once atrial systole is completed, then you have all the electrical impulses from the AV node um, properly reaching the ventricles and allowing ventricular systole. Okay, so there is an order of this. So this was false. Okay, and I hope that is now clear to everybody. Okay, if anyone wants to counter this, or they have some arguments, or they want to discuss with me, please feel free. Okay, right. So um, in this week's lectures, you guys learned about intrinsic and extrinsic electrical pathways of the heart, right? So what is that? What do you mean by intrinsic and extrinsic, right? So intrinsic is something that's there within the system. It is a property of the system, and extrinsic is something that is coming from outside of the system and regulating it from some external way. So what is the intrinsic and extrinsic pathway, right? So the intrinsic is essentially your SA node and AV node. So like was mentioned in your course materials, right? If you have a heart in a dish, it can still beat for all intents and purposes. It can still have electrical activity, even if you don't have nerves. So why is that? Because it has intrinsic regulating uh, 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 mechanism, which is its SA node and AV node, and that is where it generates this electrical impulse. But also you have extrinsic regulation, right? So what is that? So that was discussed in the coursework, right? That you start at the medulla oblongata, which, as we know, is extremely important for maintaining all these cardiac, respiratory, and so on and so forth functions. So medulla oblongata is in the hindbrain, and it has this dorsal motor nucleus of vagus nerve over here, right? And via the vagus nerve, which is you have this preganglionic fiber. You then connect to another nerve here close to the heart. That's the postganglionic fiber. And that then interfaces with the cardiac tissue. So where in the cardiac tissue? With the SA and AV node. So that is the sort of extrinsic nervous connection. That is the extrinsic electrical pathway that helps govern the heart. Right? So it has dual sort of electrical supply. It has its own, where it beats on its own, and it also has some extrinsic regulator that is able to change how fast it's beating or how slow it's beating from outside, which is from the central nervous system, right? So you have this parasympathetic and sympathetic nervous connections. It's a what is the which part of the CNS is the autonomous nervous system. Why autonomous? Because we are not willfully regulating our heartbeat. It's happening on its own. So that's the autonomous nervous system is typically in charge of functions like that. Yeah. So that's pretty much it for this bit. So I think this did I have anything else to say? No. So the receptors part, yeah, okay. So I'll come to the receptors now. So you can see this set of fibers and then this one, right? So from your dorsal motor nucleus to here, and then from this one, the next fiber to the heart, you have some interesting receptors in between. Okay. So you have so all of these nervous connections are regulated by the neurotransmitter acetylcholine, right? So acetylcholine is um, detected by the acetylcholine receptor, and the acetylcholine receptor can be of different types, right? And that was discussed that you can have based on what naturally occurring molecule or chemical it is bound by. You can have different types of acetylcholine receptors. So in the first uh, um, tract, you have acetylcholine receptors that are sensitive to nicotine. So that's why they're called nicotinic acetylcholine receptors. And in the next tract, you have one that is um, sensitive to muscarine. So they're called muscarinic acetylcholine receptors. So we'll talk a little bit about what these receptors are and why are they important for these fibers and the innervation of the heart, right? So let's go into some detail of them. So the nicotinic receptors, these are, as I mentioned, acetylcholine receptors, right? And they're receptor polypeptides, and they bind to the nicotine which is found in tobacco, right? So why are they calling it an agonist? So you guys know what agonists and antagonists are, right? So agonist is something that binds, say, to, like, instead of acetylcholine, if you have nicotine binding to the receptor, it will have a similar positive or upregulating effect. And an antagonist would essentially inhibit the same function. So it would do the opposite of that. So in drug development, if you, for instance, I work in cancer, so I, read a lot about how different cancer drugs are made. So you can like target a certain molecule and make a molecular antagonist of that, meaning essentially that you have a molecule that instead of, like, for instance, people can make synthetic analogs of existing. So if you want to shut down some pathway and there's a receptor that's particularly overexpressed in a disease, then you can make, say, an analog of the existing ligand, which acts as a, say, antagonist. So it depends on what you want to shut down or whether you want to upregulate something. And it goes and binds in place of the natural ligand. And then because the drug design is in such a way that it will bind in certain regions or cause certain configurational changes, that will lead to either agonist or antagonist like activity. So either you will see an increase or a decrease in the normal pathway based on what you're binding with. So that is just an explanation. Anyhow, so nicotinic receptors are, they respond to nicotine, and at the NMJ or the neuromuscular junction, they are the primary receptor. So very important for motor nerve to muscle communication, which is important for muscle contraction. Okay. So in your peripheral nervous system or PNS, what do? They transmit outgoing signals from the presynaptic to the postsynaptic cells, meaning from here to here. Okay. So presynaptic to postsynaptic cells within the sympathetic and parasympathetic nervous system. So that is applicable here, right? And they are the receptors found on skeletal muscles also that receive acetylcholine released to signal for muscular contraction. And another important characteristic of these guys, they are ionotropic receptors. So they're directly linked to ion channels, meaning that if acetylcholine comes and binds to this receptor, then there is going to be some ionic exchange via some ion channels. So it's directly linked to its function, right? So that is about nicotinic receptors. And I thought I'd just talk about this because it's something that's quite relevant. So, which is, what is nicotine related receptor desensitization, right? So, what does that basically mean? You know how people smoke and then they just need to smoke more and more and more. Just like any addiction, you have something called receptor desensitization. So, if you keep taking in nicotine through any force, whether it's chewing tobacco, whether it's smoking cigarettes, that binds a lot of these receptors and actually desensitizes this binding. So what occurs is that the feeling that you get from a little bit of nicotine just washes out, and then you require more and more because these receptors increase. So the rewarding mechanism that nicotine addiction exhibits has some interesting characteristics. So you have positive reinforcement. So if somebody is taking in nicotine, then they feel euphoric, or they feel happy or joyous. But then there's negative regulation, meaning if you don't have it, you can have aversive reactions. So which is like you feel sick or dizzy, nauseous. So this two kinds of biphasic regulatory characteristics are there, and this balance is what is associated with, and of course this is governed by many factors that is individual specific. So some person's personal sensitivity, how much they're smoking, how the tolerance develops, maybe even age, gender, all of these things must matter, I'm sure. But anyhow, this balance of plus and minus feelings is what can lead to this addiction properties, and they are primarily mediated molecular level, if you want to think about, is by the integration of interactive signaling processes, right, in multiple brain regions. So what happens is you have this high affinity agonist, which is your nicotine, right, and this binds to your acetylcholine, nicotinic acetylcholine receptors, and that activates these dopamine neurons. Essentially, when people say that something good happened and that gave them a rush of dopamine, what does that mean? It just means that they felt good. So it activates VTA dopamine neurons through these certain receptors. That obviously then leads to the ion channel and ionic influx, because these nicotinic acetylcholine receptors are ionotropic, and their functioning or their binding of the ligand, either acetylcholine or nicotine, is directly linked to the ionotropic function, right? So your sodium or potassium influx, that causes membrane depolarization, and this enhances firing frequency of dopaminergic neurons and triggers transient surges of dopamine release. So then that is what makes them feel good. But that is where this reward and aversion balance comes in. And so you actually end up having receptor desensitization, leading to increased addiction, and then it's just a toxic cycle. So I thought I would mention this because it's good to understand the molecular reason behind why nicotine addiction can lead to major problems, and it can just be like an endless cycle. So I guess just don't smoke or chew tobacco is the bottom line. So now coming from nicotinic acetylcholine receptors, then you also have the next type of receptors that I mentioned briefly, which are the muscarinic receptors, which are also covered, right? So these are also acetylcholine receptors, except they are a uh, different structure and they function differently altogether because they are GPCRs or G protein coupled receptor complexes, right? So do you guys know what GPCRs are? If not, I will go into just a little bit of, I think I have one slide on just explaining how GPCRs work in case anyone needs to jog their memory on how they function. But I'll just talk about the basic function of them and then I'll talk about GPCRs. So these guys, these muscarinic acetylcholine receptors, they are very important when it comes to the post ganglionic fiber release. So the acetylcholine that's released from post ganglionic fiber directly, in our case, what we were reading about is directly onto the cardiac tissue. And they're named this way because they are highly sensitive to muscarine, more so than to nicotine, right? So that specificity is why they are called this type of receptor. Okay. And these belong to a different class of receptors. So they're not ionotropic, but they're metabotropic receptors. So what does that mean? They use G proteins as their signaling mechanism. So they are not linked functionally to ion channels. So binding of ligand does not induce direct ionic changes, but it moves via G proteins, which can then lead to ionic flux changes. So in such receptors, the signaling molecule of the ligand, it binds to the receptor. And as we know, GPCRs, they all have the 7 transmembrane domain structure. And this then leads to the information cascade or the signaling cascade. So these are muscarinic receptors. So how does it essentially work? So imagine this is one muscarinic receptor. This is just a generic GPCR shown over here, right? It has these many transmembrane domains. These GPCRs are huge, okay? And they have these G proteins. So G protein coupled receptor. If you look at the name, there itself, it is clear that it is a receptor within the transmembrane region of the plasma membrane, and it has a G protein that is coupled to it or stuck to it. This is on the intracellular side. G proteins have three of these subunits, alpha, beta, and gamma subunits. So in the resting state or the inactive state, this this G alpha is bound by GDP. Okay. And if now there is some agonist, imagine that acetylcholine binds to the GPCR, or you have, say, muscarine, maybe someone isolated it from some mushroom and injected it into an animal. Then you have muscarine coming in and binding to the GPCR. Then this will activate this pathway where you have GDP being cycled through GTP. So what happens is that the this GDP cycles out to GTP, and this allows the separation of the G protein from the receptor, meaning the G alpha is becomes separate and the beta gamma becomes separate. And then these move along and go on to activate other molecules and other signaling pathways. So that's how it works. Um, Yeah, so that's so you can imagine that this is how it works with respect to the muscarinic receptor as well, that you have ACH coming in, binding here. There's a GDP, GTP recycling, and you guys may have read about GAPs and GEFs. These are what help with the GTP and GDP cycling. And that leads to alpha and then beta gamma separating, and then this can then lead to whatever changes. So in the case of cardiac muscle, it can lead to ionic flux changes, and different types of signaling cascades downstream of this, right? There are I think a lot of secondary messengers that are then regulated. Transcription factors can go into the nucleus and affect changes, right? So that's how the GPCR works. Yeah, okay. So that was just some of the details that I found particularly interesting in the first bit of the coursework. So I'll go into some questions now, and you guys can follow the same system where you can answer in the chat. Okay, to those who joined later also, please like participate and send the answer that you think is right in the chat, and we can discuss. So the first question is, why is it that five why is 5 liters of blood sufficient for normal physiology, despite the fact that it's not enough to supply all the tissues simultaneously? Right? So this was an interesting point raised by the professor, which is that if all of the body needs to have blood that is actively supplying all of the tissue at all of the time, then the 5 liters or maybe up to 6 liters that people have in their bodies, that's not going to be enough if you do the math. But how is it enough, right? Because we don't have more than that. So which of these reasons is the correct one? You can read it and let me know what you think is the right one. Anyone? Yeah, so I think almost everyone is on the same page here, which is option C. So let's look at the options. So one of the option A is because blood viscosity decreases during exercise. It doesn't make any sense. Because cardiac output remains constant regardless of external factors. So this is not true, right? Because it was discussed that, I mean, this is not true with respect to relevance also to this answer, and also it's not true in general because depending on maybe if it's like you're running or or it's cold or there's some sort of external environmental factor, your cardiac output will change. Um, and lastly, because oxygen extraction is uniform in all tissues, that is irrelevant because even if it was, which I don't think it is, blood needs to be there at the tissue at all times for this point to be valid. So the actual answer is C, because blood flow is continuously redistributed in the body according to tissue demand, right? So if you're as the professor said many times in the example, that if you're being chased by a dog, then then what happens, right? Where is your blood going if you're being chased by a dog? So the answer is that it goes to your skeletal muscles and it goes to your heart and it goes to anything that is going to keep you alive. Will digesting your lunch at that time keep you alive, or will running away keep you alive? Or, staying still and breathing deeply. One way or another, the body has a very, very clever and incredible way of prioritizing what is important at a particular time. So, in a fight or flight reflex, when you're in a situation that demands that you run away because it's dangerous and you got to get out of there, then your blood flow is redistributed based on which tissue demands it at that time. And at that time, if you're running, your blood has to go to your calf muscles, it has to go to your thigh muscles, it's got to go to your heart. So those are the places where you're going to have a lot of blood being redistributed to, and therefore the blood vessels um, in your gut, for instance, will constrict, and there will be less blood being rerouted to the gut, because at that time that's not important. So yeah, uh, the answer here, correct one, is C option, and that's why. So we're just in a constant mode of prioritization. And in general, also, like, I think you don't always have to be chased by a dog for this example. Like, even in under rest conditions, there is a prioritization when it comes to even in homeostatic conditions, and you probably don't have all the blood, going to your gut, but right after a meal, you would have more blood going to your gut. So maybe you feel a little slower after a meal. Why? Because it's all the focus is on digesting. Yeah. So, okay, let's go to the next question. So during exercise, the stroke volume of your heart, right? It increases primarily because of which of these reasons? Yeah, fantastic. So I think everyone has got it. It is option C, which is increased ventricular filling and stronger contraction. So this makes sense, right? During exercise, you need uh your heart, it beats faster, and it beats such that blood is redistributed faster based on the requirement of your muscles in your body. So you therefore have stronger contractions and more blood filling into the ventricles. So it's much more powerful, and it keeps you going during exercise. So your stroke volume is increasing primarily because of these reasons. Okay. So then you were also taught one law or mechanism, which is the Frank-Starling law of the heart. So, what does it state? Do you guys remember from? I didn't sort of reiterate it here, but do you guys remember what you read? Yeah. So, yeah, the right answer here is, I think all of you got it, which is option C. The heart pumps out exactly the amount of blood it receives. So, as it was explained, right, you cannot have pooling of blood. You cannot have pooling of blood in the heart. You have to, however much, because it's such a dynamic organ, and it's like a conduit, right? You receive, and then you expel, and then you receive, and then you expel. So this has to keep going, and if you accumulate like a dead volume every single time, then that is going to completely disrupt all of these volumetric sort of uh, steps in the heart, right? So however much blood it receives, even if you're sort of during an exercise condition, if your stroke volume is increasing, there is an equal and opposite increase in filling as well as expulsion of blood. So that keeping it equivalent on both sides is what's required, and that's what the Frank-Starling law states. Cool. So let's move to the next question. Which of the following correctly describes parasympathetic innervation of the heart? So, what do you guys think? Yeah, yeah. So I think everyone is on the right track. It is option B. Yes, great. And I'm glad so many people are participating. That's nice. So, it's indeed correct. Both the pre and post ganglionic neurons, like I mentioned, release acetylcholine. One of them is has like there's sensitivity of the pre to by via the nicotinic receptor, whereas there is sensitivity to the post ganglionic release via the muscarinic receptors, right? But they're still both releasing acetylcholine. They're still cholinergic, right? So I hope that is clear. Cool. So now let's move to the next question. I hope that's clear. Yeah. So pain from angina pectoris, I think angina pectoris was mentioned in the coursework, right? It's referred to the left arm and shoulder because of what reasons? Right? Aside from pain in the chest, one might also get pain in left arm and left shoulder. Why might that happen? Yeah, I think everyone's on the right track. The answer is B, which is that the same sensory neurons that receive input from the heart and the left are also received from the left upper limb and shoulder region. So it's like there is a misinterpretation of these signals. So while there isn't actually any real pain in the shoulder and the left upper limb, it's just it feels that way. And something I was reading about that's interesting here is how, and this is like a very sort of now preliminary evolving field of medicine, which is what are the gender-based differences in presentation of these very common disorders, diseases, and acute problems. So, angina pectoris is quite acute, meaning that it occurs uh, suddenly and it occurs like immediately. It's not something that sort of develops slowly over years and years. If there's someone has angina, then someone has angina, like right then itself. So in these kind of acute conditions where someone shows up at the emergency room with at the hospital saying that, oh, I have I have this pain. That actually is very different, not very different, but there are distinct differences in how these are presented, like angina or say an oncoming heart attack, how it would present in um, on average in women versus men. So while men have symptoms in, so again, this is based on just broad comparison of data, like metadata that was compared in certain papers. And I was just reading about it and I found it very interesting, which is so men will present with this left upper arm and shoulder and chest pain, and women also present with that, but it's also like women have said on average more that there is a burning feeling, a burning sensation, also nausea and dizziness, which has been described more. So whether this is just because women like describe things better, or whether these are actual genuine differences. But the point is that there's this field evolving now that looks more at these gender-based differences, because it's important in the clinic to differentiate these things, because a lot of the studies, and I'm sure you guys know about this, but a lot of these studies and a lot of like, okay, so this disease has this symptoms, this has been with respect to the male body. So the female body has not been sort of given as much relevance with respect to this so far. And so then now people are realizing that, oh, okay, so it's different for, it may be different in women's bodies. It may show up differently in women's bodies, right? Just like how looking at how things evolve in kids is different, right? So how a child would experience certain kind of pain, it's a whole different branch. So now people are looking into gender-based differences. So it's just something I came across when I was reading about all this, and I thought I'd tell you. Right. So that was an aside. Now back to the course material. So muscarinic acetylcholine receptors differ from nicotinic ones because of which characteristics of muscarinic receptors? This is something we discussed, so I think you guys will get this one easily. Yeah, so I'm getting a lot of answers and everybody has got it right. Great job. It is option D. They are G protein coupled receptors or GPCRs. Right? So the pentameric ligand gated channels, these are actually nicotinic receptors. That's the structure that they have in the bound state. And yeah, the others are just untrue. So yeah, great job. So yeah, now we'll come to the, I think, last bit of the course material that essentially looked at hemodynamics, right? So this is essentially the regulation and the dynamicity of the vasculature and how blood flow is regulated in the body. So this is again from your coursework. I'm sure you're familiar with this image, right? Where you can see the different flow rates, which would give you an idea of like how much percent of blood is sort of moving on average from the heart to different systems of the body, and what is the pressure, right? The mmHg is the pressure, right? So what is the pressure in those organs and in the blood vessels um, close to those organs? So when you have blood entering into the atria, right atria, you have through the vena cava, you actually have it at quite low pressure. So and then it moves to the lungs. And it was mentioned in the coursework, right, that it's important that in the lungs you don't have a very high pressure, because that could lead to too much fluid extrusion, which could cause fluid buildup. And what would happen if your alveoli are surrounded by liquid? Right? Alveoli are what? I hope all of you know what alveoli are, right? They are these little bulbs at the ends of your so you have the your trachea that branches, that goes into the bronchioles, and then eventually you come down really really small into the um, finest of the branches of the bronchioles, and then you have at the ends of them, you have at the tips of them, you have these alveoli, right? So they're little sort of bulbs which have very, very thin membrane that allow for gaseous exchange, so oxygenation of blood, um, and the release of CO2. So gaseous exchange occurs there. Now, if you have high pressure in the lungs, in the capillaries of the lungs, what will happen is that if you have pressure, it can lead to excessive tissue fluid filtering. So more fluid sort of leaks out of the capillaries and it starts filling up in the lungs. And then your alveoli are surrounded by liquid. So how is this exchange happening, right? It's you just have this tissue fluid filling up all the spaces. How is the gaseous exchange taking place? So that's why the pressure needs to be very well regulated when it comes to the lungs. It shouldn't be too high. And obviously, there's why would something not be too low? It's because then it wouldn't move through at all. It would just pool there. So there's a perfection in the body. There's always a healthy range of all of these things. Then it leaves the lungs at a lower pressure, reaches the left heart, and then you suddenly have a burst of increase in the pressure. Why? Because your ventricles, once it once it gets to the ventricles, you have a burst of contraction, and that sends the blood into the body. So, and this is very interesting because you see they're saying right heart and left heart, right? So what does that mean? So you the same heart has two different pressures maintained simultaneously in concert. How crazy is that, right? So your right heart is sending blood to the lungs at a sort of lower pressure, whereas the left heart, which needs to send blood to regions much further away in the body, like the kidney or the skeletal muscles in the legs, like how far is that, right? So left heart needs, and that's why the left ventricle has such strong musculature in the ventricles, right? Much thicker musculature in the ventricles because it needs to really pump to very, very, far uh, like placed organs. And so you have this huge hike in pressure, and that then allows the blood to circulate into these different organs in different amounts. And then it filters through, and during this time, obviously, it reaches. So you have your arteries branching into arterioles, which branch into smaller, smaller, smaller capillaries. And these capillary beds, they have a pressure roughly around 30 mmHg. And during in that while the blood is moving through the capillaries, you have fluid filtering out, right? So that forms your tissue fluid. There's lymphatic drainage, and all of this then is collected into your venules and then your veins, and they have a much lower pressure, and then that eventually moves into your right heart. Okay, but you'll notice that the same amount of blood over here is the same, and it's same over here, right? Because how much goes in, same amount will come out of the heart. So that was the law that we talked about earlier. So yeah, that's a recap of this important concept. And so then there were these two things that were talked about in in the class, but in not too much detail. So I thought I'll tell you guys a little about it. So varicose veins and what is called DVT. DVT is deep vein thrombosis. So these are slightly different from one another, and essentially they are conditions where there is a dysregulation in this in the vascular uh, conduction of blood, right? So what happens in a varicose vein? And you can read about it more at this. I got it from a Baylor College medical website. So essentially, there is an increased blood pressure in superficial leg veins. So you have superficial leg veins and you have deep veins also in the muscle tissue, right? So in the superficial veins, meaning superficial means it's just closer to the skin, right? These varicose veins will occur in the legs. And why does it happen? Because when you have blood moving through these veins in the legs, for instance, they have to work against gravity in order to go up, right? So once you have blood here, it has to go all the way back up into the vena cava. So how is this one-way movement? Does someone have something to ask? Okay. Uh, okay. Okay. Right. Cool. So if so if the blood is moving upwards, how is this happening, right? Why isn't it just flowing back down, right? Gravity should that's what should happen. But what allows this to be one way is the valves in the veins. So we know that veins have valves, whereas arteries don't have valves. Okay. Capillaries have sphincters, which you guys learned about, right? Which controls sort of which capillaries are getting blood, which tissues are getting blood. But valves are not there in arteries, valves are there in veins, and that's what allows them. So, like if the blood goes through them, they just sort of snap back if the blood tries to come back down. So, when the leg muscles contract and squeeze the deep veins, the valves inside the veins open, and when they relax, the valves close. So, that prevents the blood from flowing backwards, like how gravity would make it. So, now when the one way valves become weak or damaged because of some reason or the other, the blood can collect in the veins, and that causes the veins to become enlarged, like you can see over here in this image. So a lot of people who do jobs like where they're sitting or standing for a lot of time and they don't sort of exercise in between, take a little walk or do something to make sure that the blood is not pooling in their leg veins, that can cause an increase in the pressure within these veins. And in the people who are prone to this increased pressure can cause weakening of the walls of the veins, damage of the valves, and then these kind of spidery looking veins. This morphology is seen. So that's just because of damage to the blood vessels at the superficial veins. This typically you don't see in younger people. It is sort of correlated with age, but of course it can also happen if someone has some injury or because of smoking or some hormonal changes or some people just inherit it. Um, so you can see it in these cases. And it is not apparently a very severe medical condition, though it can be uncomfortable and it can lead to further problems. Like I do know of cases when I was reading about this, I found out that it can also then lead to DVT. And obviously people, may be concerned about how it looks. So now what is DVT? This is a more sort of serious version of this, where the deeper veins that I mentioned that are supplying blood to the muscles, they they can essentially have this embolus forming in them. So deep vein thrombosis. So what does thrombus mean? Thrombus is a clot, right? So in a deep vein, if you have a clot formation, and that can lead to swelling of the vein and it can lead to this thickening of the artery, which also increases pressure inside the vein, also can present like varicose vein. But this is something that requires very immediate medical attention. Why? Because if this blood clot is there in the leg, I mean, in the leg, it causes a lot of pain. That is there. You'll have leg swelling and there will be a lot of pain. But also, if this clot gets dislodged and it moves through the blood vessel, it can go to the brain or the heart. Now, what can happen if there is a blood clot in the brain or the heart? It can cause a stroke, right? because it will clog an artery there in the brain or in the heart, and that can lead to a stroke. So that's very dangerous. So DVT needs immediate treatment, and I think people do like catheterizations, or they give like certain drugs that can help to dissolve these clots, or maybe there's even surgical procedures, I think, that can tackle this. So yeah, then this is all because of some weakening in the veins in the legs and pooling. So pooling is not supposed to happen. So it's best that you just, exercise when possible, and don't sit or stand for continuously for too long without some amount of movement. Okay, that was about varicose veins and DVT. Now I think, yeah, I have some questions that we can go through, uh, and we can discuss as we go, right? So does anyone have any questions about anything else we've discussed so far? Let me know. Anyone? No, no? Hmm. Okay, great. If anything comes up, you can let me know. So let's go through some questions now. So in the cardiovascular system, okay, this one is easy, okay? The primary site of exchange of gases, nutrients, and waste products is where? I'll just be back. Yeah, sorry about that. So, yeah, you have got it right. Everyone's got it right. It's capillaries. So, as we mentioned, capillaries have the thinnest walls. They have 30 mmHg pressure in them, which allows this filtering to happen, and they are present uh, near all of these near tissues of all of the organs, because every organ requires oxygenation and removal of waste products and addition of nutrients. Okay, that's an easy one. Next one. So the average pressure of blood entering systemic capillaries is approximately how much? Yeah. Yeah. So I think that's perfect. Everyone is getting it. So it's, as I unfortunately mentioned already, it's 30 mmHg. So that's the pressure. And then when it's leaving the capillaries, it's much lower, right? It goes down. Okay. So despite their thin walls, right? Capillaries have very thin walls that allow filtering, but they withstand all of this blood pressure. How is it that they're not bursting? So what is the reason for that? Yeah. So I think there is some confusion in the answer. So the right answer here is D option. Though I think maybe some amount of B would be correct too. But like I think B is just a cause, sorry, B is a consequence of D. So let me explain. So capillaries withstand blood pressure. Why? Right? Capillaries have thin walls. If you just had a single capillary that was connected to the complete arterial blood flow of one organ, that capillary would explode. But what's happening is that this blood is dividing and dividing via arteries and arterioles and then into capillaries, right? So you have many capillaries. It's a whole network of capillaries that allows the distribution of blood to organs and tissues. So while this division is taking place, you are actually increasing the effective radius. So that's what's allowing it to withstand the blood pressure. And because you're distributing the blood like this across a network, therefore the blood pressure drops. So D is the reason and B is the consequence of that. So that's why the answer here is D option. I hope that is clear. Yeah, cool. So then if no one has anything else to ask about this one, then I'll go to the next question. So the normal cardiac output entering the right heart per minute is approximately how much? Do you guys remember what was taught? Yeah, great. So the correct answer is 5000 ml or 5 liters per minute. So 5 liters per minute going in and coming out of the heart. So we are entering the right heart at that. Okay. So great. Glad you all got it right. Let's move to the next question. So which pressure range correctly represents right ventricular systolic and diastolic pressures? This one, this is something that was sort of repeated a lot during the lessons. That it was something that the professor said is important to me. What do you guys think? Does anyone else want to try? So, yeah, I'm glad that some answers have come in. So, the right answer here is C option. Okay, so um, I think there is some confusion about this one, right? So, the correct answer for right ventricular systolic and diastolic is 25.8 mmHg. So why is that? Because right ventricular pressures, which are normal, for resting for an adult, the right ventricular systolic pressure is roughly between 15 to 30. So on average, 25 mmHg, and diastolic is 8. And these are low pressures, and that's what reflects right ventricular pumping because it is a low resistance pulmonary circulation, meaning there we do the right heart does not need to pump with so much force because it's only pumping to the lungs, and the lungs are not that far, right? But the left heart is pumping to the whole body. So that's why the pressures on that side of the heart, on the left side, are higher. But this is low resistance pulmonary circulation, right? So the job here is to push via the pulmonary artery and push blood to the lungs. So that much high pressure does not need to be generated, right? So and also the right ventricle wall is thinner also, so it cannot use so much. It cannot generate such a high pressure. Yeah. So this is what it's called. This 25/8, or I think in clinics it's called 28 mmHg. So this is an important sort of clinically relevant value, and that's something that I guess if you're looking at, heart function and so on, that would be something that they would check. So this is the pressure in the right ventricle when it is relaxing and filling, and then when it is in systole, which is pushing the blood to the lungs. Right. So I hope that is clear. Great. So this one might ask, right? So this 120 by 80 is some figure that you guys hear a lot, right? When people are like, oh, okay, that person's blood pressure is normal. Their BP is 120 by 80. So that's it's normal, right? So that you might have heard a lot with respect to, in the clinical setting or with some family member or something. So what is that? So if 25/8 is right ventricular systolic and diastolic, what is this 120 by 80, right? So that is your systolic arterial pressure. Okay, so it's the pressure in the that's sorry, the 120 is your um systolic arterial pressure. So this 120 by 80 mmHg is just talking about your systemic arterial blood pressure and not your actual ventricular pressure. So 120 mmHg, this guy, 120 mmHg, that is your systolic arterial pressure, the pressure in the aorta or in your larger arteries. So it's measured when your left ventricle is contracting, and with left ventricular systolic force, there is blood rushing into the aorta and into the arteries, major arteries. And then the 80 mmHg, which is there, that is the diastolic arterial pressure. So in between, when there is a relaxation, right? Systole, diastole, systole, diastole. So there's a relaxation. That is when there you have diastolic arterial pressure. So this elastic recoil of the arteries is what allows this rest or lowering of the pressure to occur. So this is with respect to arterial blood pressure, and this is with respect to the atrial, ventricular systolic and diastolic pressure. Yeah. So that's the difference, but I can understand why it is confusing. Yeah. So let's move to the next question. So blood returning from the lungs to the left atrium has an average pressure of how much? This is important if you just remember why it needs to be this value for homeostasis. Right. So I'm getting I'm getting all different options. But the correct answer here is A. Okay, it's 5 mmHg. So let's go back to that diagram. You can see this now. So right heart, when it is reaching your right atrium, basically, look at the pressure here, 4 mmHg, roughly 4 to 5 mmHg. Na? So when it's in the capillaries, it's 30. And then by the time it filters out and comes back through the venules and all, and it's reaching the vena cava, the pressure has decreased substantially. So you're down to about 4 to 5 mmHg. And that is what goes to the heart. Because if you have high pressure, you're going to have problem filling the atria. So the right heart, for proper atrial filling, the pressure needs to be low. So you have low pressure of around 5 mmHg. Okay. Uh, yeah. Okay. So I hope that's clear now. So the correct answer here is A option. Okay. All right. Next question. So among these options that I'll show, which organ receives the largest fraction of cardiac output at rest? This is just something if you remember from the class. Hmm. So actually, okay, I have different answers coming in. So I can see why you would think it's brain because brain's got a brain's got a function and you think that all the blood actually goes maximum to your brain. But actually the correct answer is GIT. Yes, it is gastrointestinal tract. So funnily enough, though it is kind of counterintuitive, I guess, the GIT, which is called this, oh my goodness, I don't know how to pronounce it, Splanchnick circulation, I think that has about 20 to 25%. Yeah, exactly. This is surprising. 20 to 25% of the circulation, of the cardiac output goes to the GIT. Then about 15% of it goes to the brain, hilariously. And then I believe, I think your skeletal muscles gets about 20%, and your kidneys get about 20% or so. Skin gets quite less. I think maybe like 8 to 10% at max. Heart itself apparently does not get that much. You would think that the heart, which is doing so much and is, receiving blood via the coronary arteries, it would get a lot of blood to be able to oxygenate its own cardiomyocytes, but it only gets about 5%. So, yeah. And then, the others are distributed here and there in other organs and stuff. But yeah, here the correct answer, surprisingly, is GIT. Okay. So that's about 20 to 25% of the blood, the cardiac output. Okay, next question. So during exercise, increased blood flow to the skeletal muscle occurs primarily by which of these mechanisms? Do you guys know? Yeah, so this one we nicely discussed earlier also, and I think you guys have got it, which is option D, redistributing blood from, yeah, less active organs. So, for instance, from the GIT, this cardiac output that the GIT is receiving, this is very importantly, the point is that it is under rest conditions. But during exercise, which, this entire balance will be changed and blood will be redirected to the skeletal muscles from, from your GIT, for instance. Cool. Next question. The renal blood flow remains relatively constant during physiological stress because of which of these options? So you have all of these environmental factors and different kind of changes and all. Maybe if you're running, would your renal blood flow change? Would the pressure and the output in the kidneys change, or would it stay the same? And if it does stay the same, then why? Hmm. So, do you guys remember? I think if you've studied, in school and all that about the kidneys and what they do, right? So they have this glomerular filtration that takes place, right? So what happens there is that you have these nephrons, which have these glomerulus, which have these little sort of baskets of capillaries where you have the blood filtering through, and this is a important process for sort of purification of the blood and production of urine. So during that time, the pressure needs to be regulated. There was this afferent and efferent arterioles leading to the glomerulus, right? And all of these filtration processes require what is called steady perfusion. Steady perfusion is a fancy way of saying that the pressure should stay the same. The pressure should remain constant because glomerular filtration otherwise would have some sort of pathology. So the renal blood flow, even if it's changing for other organs, the renal blood flow will remain relatively constant during any different sort of physiological events. So the option here is B. Glomerular filtration requires steady perfusion. And the others are just wrong, right? Kidneys lack autonomic innervation. Renal arteries have no smooth muscle. That's not true at all. Renal capillaries have unusually low resistance. That's not true either. Okay. I think we have like maybe five more questions. A pressure gradient is essential for blood flow because this is this is just a physics concept, essentially. Yeah, exactly. Great. Exactly. So the pressure gradient is essential for blood flow because the fluids move only when pressure differences exist, right? Imagine two balloons connected to each other which have some amount of fluid, right? And there's some amount of air also, some amount of fluid. Now, if I'm holding the two balloons in my hand and they're connected to each other, mind you, right? And then I'm just holding them, then the liquid will equalize and there will be no flow. But if I were to squeeze one of the balloons, then I'm applying a pressure. So there is a gradient. So fluid will move from one balloon to the other. So that is what is also a similar kind of analogy can be used in blood flow, where you are squeezing the heart and fluid is moving in that direction towards the rest of the organs. Okay. Failure of venous blood to return efficiently against gravity, leading to pooling, can result in which of these? Uh, hmm, which of these pathologies? Yeah, so everyone got that. Great. It's varicose veins. So if you have pooling of blood, it can lead to and there's some valve failure or weakening of the walls. that can lead to these highly prominent varicose veins, uh, typically seen in the legs. Okay, next question. The compliance of the aorta is physiologically important because of which of these reasons? So, if you guys remember what compliance is, it's just a way of saying that if something is stretchy, how stretchy something is, how easily stretchable. Hmm. So, the right answer here is C option. It maintains continuous blood flow during diastole because the aorta is going to be contracting and relaxing. So, um, this sort of continuous pattern of contraction and relaxation is what allows the blood to keep moving even when the ventricles have relaxed and the blood is not actively pumping through. It is the compliance of the aorta that allows the blood to keep going through and not like stop. Okay, next question. So the precapillary sphincters, and I mentioned these earlier, right? These primarily regulate blood flow at the level of which of these? So this is directly from the um, coursework. Yeah. So I mentioned that these sphincters are important for like deciding where blood is going, right? Which capillaries it enters. So if it is at a decision making point, then it has to be from where the capillary starts. So the capillary entrance or the meta arterioles. Essentially the very sort of when the arterioles have branched right towards the end, that's where the capillary sphincters are there. And they regulate blood flow and decide which capillaries are getting blood in them, which are not, which tissues are being supplied with blood at that time, and which are not. Okay. Which statement about veins is correct here? Yep. Yeah, great. All of you have got it. It's B option. Veins store most of the blood volume at low pressure. So we know that veins have high compliance and they are have thinner walls, right? So when the cross section of these blood vessels were shown in the coursework, right? You had seen that the arteries have a thick tunica media, right? A thick muscular, a middle muscular layer, whereas veins don't have such a developed one, and they have a higher like they have a higher diameter, more sort of, and because of this higher diameter, they are actually storing the blood, more of it, but at a lower pressure. Okay, so most of the veins do so at a lower pressure. Okay, and this is the last MCQ type. So, the constriction of blood vessels supplying the alimentary canal during sympathetic activation occurs because of which of these events? So, can you guys figure it out? Does anyone else want to try? So, uh, the correct answer here is D option, which is the last option. Increased norepinephrine causes smooth muscle contraction. So, it was mentioned in the class that norepinephrine has a very interesting like role. It has a dual function. It's not just inhibitory and not just activating, right? It doesn't just increase or decrease certain functions. It does both depending on the context. So, for instance, in smooth muscle of blood vessels in the alimentary canal, there are these alpha 1 adrenergic receptors, and norepinephrine via these receptors causes constriction, right? Whereas in the skeletal muscles of in the skeletal muscles, the blood vessels that are there, they dilate via norepinephrine activity, but this is via a different set of receptors, which are the beta 2 adrenergic receptors. So you have the same norepinephrine doing two different jobs via two different receptors based, and this is distinction is only because of the type of tissue that it is in. So the tissue specific receptor expression is governing the effect of norepinephrine, and that is a sort of dual effect. It is increasing in one, matlab constricting in one and dilating in the other, right? So in this case, constriction of blood vessels that are supplying alimentary canal in sympathetic activation. So many people think that sympathetic nervous system, it does what? It just makes you ready for fight and flight. So it increases everything. But actually that is a little bit of a misconception. The hormone norepinephrine does both of these things, right? So in this case, it's D option. If you have more norepinephrine being secreted at maybe at the level of adrenal medulla, that causes smooth muscle contraction in the blood vessels, leading to constriction of the blood vessels in the alimentary canal. So what would happen then if it's constricted? Volume is reduced. So then what would happen? Less blood in the blood vessels in the alimentary canal. Instead, they are shipped off, that blood is shipped off to the skeletal muscles, and where those blood vessels have dilated. So now there's more volume there. So you have less volume in GIT that's going to the blood vessels in the skeletal muscles where there is more volume because the blood vessel is dilated, and that is then supplying more blood to the skeletal muscles that actually need it because of some event that has caused such sympathetic activation, right? So maybe you're running away from some danger or something. Okay, so those were the MCQs. And the last part is this one, just a small maths problem. I hope you guys don't curse me. So we'll calculate mean arterial pressure. So do you guys remember how mean arterial pressure was calculated in your coursework, right? So there is a way of doing it. So if a person presents with say 110-60 mm Hg BP reading, how would one calculate this? I think this is a quite simplistic way of doing it, but how would on average one calculate their mean arterial pressure? So can you guys do it and tell me how much it is? So there was a formula, right? I've just followed that one. Does anyone else want to try? Okay, so the right answer here is roughly like 76, 77 mmHg. So how does one come to this answer? So this is the formula. So mean arterial pressure is 2 into diastolic plus systolic BP totally divided by 3. Okay, so if you take the diastolic reading, what is the diastolic reading at 60? So 60 multiplied by 2 is 120 plus the systolic, which is 110, making it 230. So 230 divided by 3, that's approximately 76.66, so that's approximately 77. So this person who has 110/60, which is a little low, right? Their mean arterial pressure is low. It's 77 approximately mmHg. Okay, so that is how you calculate. So there's one more example now. You can apply the same formula. This person now, another person has come to you with 140/90 mmHg BP reading. What is their mean arterial pressure? Can you calculate? This roughly will do. Exact all decimal and all you don't need to um, go for. Yeah. Yeah, fantastic. So all of you have got it now. So if you apply the same formula, which is 2 into diastolic plus 1 into systolic whole divided by 3, right? So you get 90 into 2, 180, which is your diastolic into 2, plus 140, which is 320. 320 divided by 3, it's roughly 106 to 107. Okay, so the correct answer here is 107 mmHg. Right, so now you also know how to calculate the mean arterial pressure. And that's it. I think that's all the questions I have for today. Yeah. So, does anyone else have any questions? If not, then I think for today we can conclude the Q&A session. I hope it was useful for you. And I'll see you guys next week at the same time. We will discuss the next week's coursework. Yeah, thank you all for attending. And I do upload these slides, as you know, as a PDF in the shared, like this. There's this Google Drive folder, so it's there available there. So if you need to check it out later, you can. This stuff is also uploaded to YouTube, this session, so you can also refer to it later if you miss something. All right. Okay. Thank you all for attending. I'll see you
Thank
guys.
you, ma'am.
Thank you. Yeah. Oh, someone has a question. How do you find questions for assessment? Like, are you talking about the assignment questions in NPTEL, or are you talking about the questions that I showed? Because as I mentioned, I will upload this stuff, so you will be able to see it. It is It's shared within the NPTEL, like the portal itself. They, I think, share it. So if you, on the left, you have your week 0, week 1, week 2, and all of that. So I think if you go down, there is, they provide this link that opens up to a Google folder, which has details of all of the scholars who are giving TA lectures and Q&A sessions, and those details will be there. So I'll be uploading links to the YouTube video, and there's a link to a Google Drive folder where you can get this. And for your assignments, though, it's available in the portal itself, right? Okay, all right then. I'll leave now. All right. Thanks a lot, everyone. Bye bye.